I'm Roger Baker, Executive Director of the Stratfor Center for Applied Geopolitics at RANE, a global center of excellence for geopolitical intelligence and analysis. Learn how you can put geopolitics to work for your organization at ranenetwork.com.
Hello and welcome to the RANE Insights podcast from RANE Network. In this episode, founder and chief collaborative officer of RANE, David Lawrence, sits down with Dr. Mark Gold for part 3 of their discussion on the United States of addiction, dealing with the opioid crisis in the medical community and beyond. Dr. Mark Gold is an author, inventor, mentor, and world-renowned expert on addiction-related diseases. Dr. Gold has had over 1,000 peer-reviewed publications since beginning his academic career at the University of Florida College of Medicine and Yale University School of Medicine in the 1970s. Dr. Gold has modernized addiction and psychiatric training, fellowship, and treatment programs while hopeful that research would translate into new, more effective treatments. Check out Dr. Gold's full bio and host of written publications at psychologytoday.com. We hope you enjoy this episode.
Mark, once again, a privilege and an honor, and I feel we have a lot to catch up on because, as usual, you have been prolific in your writings and your speaking on the issues of addiction, substance use disorder, and what's happening to young people in America. Maybe I'll give you the floor and you can talk about what you have been particularly focused on in the last month or so. And again, congratulations on the great articles in Psychology Today. We'll post that alongside this podcast.
Well, you're kind as always, and I really appreciate you and the audience for wanting me back. The fact is that my role in this is look around, see what's going on, maybe see what other people aren't saying, try to say things a little ahead of the curve and help people understand what's the current state of the drug crisis and what we can all do to make it better. So probably since the last time you and I did this podcast, it probably is a month. So there's maybe 8 different things that I covered, but I do think some of the big picture items that are worth considering, we touched on it a little bit, which is the huge headlines about the U.S. drug overdose deaths decreasing and all the good news around that. I tried to put that in perspective in one of my articles in September, and then the continuation of the teen counterfeit drug overdose crisis. I think that's worth highlighting, as well as just the overall kind of deaths of despair and self-medication that we see in teens and young adults that seems to be underlying much of the shift in drug use patterns, which you could highlight in a University of Michigan high school survey as, alcohol and cannabis use are going down, but miss the fact that so many things are going up, and among young people, overdose is all too common cause of death, as is accidents and suicide. So really, those big 3 account for the majority of deaths in young people nowadays, that we have so many good treatments for everything else. And that's a big megatrend that we see going in uninterrupted into 2025.
So let me unpack a little bit of that, which is, let's go back to the beginning here. There was, from a headline standpoint, good news about the deaths from fentanyl. But as you pointed out in your article, there's good news, yes, but there's a lot of bad news, and there's a comparative analysis that one needs to take a look at. Could you perhaps share with the audience your interpretation of the statistics that were disclosed?
Yeah, so just on a raw basis, the big headline number was that opioid overdose deaths dropped from about 85,000 in 2022 to about 81,000 in 2023. So yes, that's a significant drop, but put in perspective, the United States has 4% of the total world's population, but 20% of the total world's overdoses, that we would still have more overdose deaths than the top 10 all added up and put together. So you'd say, well, that's a big change, and we should compliment ourselves. I would say, yes, it's a good change, but also cocaine deaths have increased. Methamphetamine deaths have increased. And in one way, we're playing a game of whack-a-mole. So we started off with an opioid death crisis that was based on prescription medications. That morphed into an opioid overdose crisis that was based on heroin. That morphed into a fentanyl crisis. Currently, more people are dying from smoking drugs than they are of injecting or taking them orally. So we have a smoked fentanyl crisis. Then we have speedball, meaning the combination of opioid and cocaine or methamphetamine. That could be smoked or injected, and those deaths are increasing. So yes, I think it's clear that the idea that the more people that have naloxone who are using opioids, or their loved ones have had an opioid use disorder, the more naloxone out there in EMTs, vehicles, and available, the more overdose rescues. Then we are now trying to do a better job of helping people who've been rescued enter treatment. That's also helped. But when you look at the total numbers, it's very small compared to the number of people that we seem to have in almost an evergreen drug crisis in the United States, meaning that no matter how many people die, they seem to be replaced by other people. A couple of other things that you might not know in the data, which was within the data, there are big state-to-state differences. So Ohio did very, very well and had a significant decrease in overdose deaths, as did Massachusetts and Connecticut. On the other hand, Washington State and Oregon, actually in the midst of all of this good news, had increases in their overdose rates. And I'd suspect that that's part of the reason that the citizens have, when given a chance, tried to change those states or major cities' policies. Washington actually had, I can't remember exactly, but I'll say a 40% rise in deaths, as did Oregon, at the same time that almost all the other states had decreases and some had huge decreases.
So your view is that one has to look at this holistically in terms of, I'll put it, a whack-a-mole issue. Some things go down, but other things pop up.
You know, I mean, everyone liked the show, but it's useful to remember that it's good practice to curb your enthusiasm. The total number of deaths overdose deaths in Canada in a year is 7,000. We're like still close to 100,000 drug overdose deaths, right? Like Australia, maybe it has 2,000. Germany, about that. United Kingdom, maybe 4,000. Like if you just take comparable nations, we have so many more drug overdose deaths than you would expect. And I do remember when I was at Yale and we were just getting our hands on naloxone and being able to reverse people who had overdosed in 1974, 1975, that at that time, I'm going to guess again, but I mean, I think the total number of overdose deaths in the United States was like it is in the other Western countries, in the 3,000, 5,000 a year. It was so low that when naloxone was introduced as this wonder drug, life-saving drug that could reverse overdoses, many of the emergency rooms said, why would we ever buy this drug? Because we've never seen somebody come in with an overdose. Like, it was so rare, and it was really the fact that it was used by anesthesiologists in surgery to reverse opioid effects, and they carried it around and brought it into every surgery. That was the lifeline that kept naloxone alive as a medication, because it was really an orphan medication for many years as far as the emergency departments were concerned. So anyway, I think we have. You could. I did an analysis which is probably very unpopular, which was to just look at the law of large numbers and just try to see how much of the reduction might just be due to the fact that so many people have died and how many more people are available to die.
Unfortunately, as at least personal narratives attest, Mark, families are suffering from the loss, and I know you have made the point before that the mere fact that an overdose is reversed is not taking care of the issue. It is treating a symptom, and clearly more has to be done so that not all the entire tale is not told through the statistics of overdose.
Yeah, no, I agree. I wrote one of these articles about what is an overdose, and I just think there's a lot of misinformation about that too. Like, is an overdose like a sneeze or a cold? Like, if you reverse an overdose, what does that really mean? Does it mean that you're just as good as you were before you overdosed? And what's the residual effect on the brain particularly, but also the heart? So you have cardiovascular effects, and we reverse that and people wake up, that's pretty clear. But there is a question as to whether an overdose reversal equals a concussion in severity. So if you have 10 concussions, are you different than a person who's only had one? And how should we keep track of overdoses? There is brain imaging data that I have reviewed, and that the head of the National Institute of Drug Abuse, Nora Volkoff, is a co-author on one of the only papers to look at this. I do think it's University of Pennsylvania data, but it's troubling because fentanyl being so powerful and so able to induce an overdose, the resistance to reversal is increased compared to heroin, meaning it's harder to reverse somebody, but also there just may be residual effects that we don't know because we don't look at that. We look at reversal of the overdose as a success. Of course, I agree, it's a success, but it would be much better if we prevented it, and it would be much better if a person who did have an overdose and was reversed sees this as an opportunity to enter treatment and not have another concussion, if you will.
Duly noted. Something that you and I have spoken about privately before that I want to speak about, because as long as people are saying good news, bad news, etc. One of the things that I have noted is that statistics around addiction, overdoses, etc., tend to lag, reliable statistics tend to lag by approximately 2 years mark behind where we are. And at a time where the rest of the world is operating on real world data or something close to that, real time, I sort of wonder why that continues to be the case. And I was reminded about it today because Steve Ballmer, the former head of Microsoft and current owner of, among other things, the Los Angeles Clippers, launched a terrific not-for-profit effort to basically mine the various data streams that come out of the government to help better inform the citizenry about what's happening, where their taxpayer money goes, what issues are surfacing, etc. And his most recent analysis was around accidental deaths in America. And he was reciting the statistics from, with respect to drug overdoses broadly, wasn't limited to fentanyl, the best he had in terms of government statistics were back from 2022. And here we're approaching the end of 2024. Can you maybe, I know this is something that you've focused on, but maybe help the audience understand why these statistics lag and perhaps what can be done about it?
Yes, well, this would be really helpful. So congratulate him if you do speak to him for me. It's been an ongoing crisis in our field. It's actually worse for teenagers. Most of the analysis that's been reported for teenagers is like 2022 data. That's about, like, when people say drug overdose is the third leading cause of death among people under 19, that's actually from 2021 CDC data. The challenge has to do with the source of the data. So if, God forbid, there's an overdose in a certain locale, that person tends to have a death certificate filled out by the local coroner. Now, the difference between accident and suicide is usually based on history, a note, but the intent of the person is left to the coroner, the forensic pathologist, to determine. So there's considerable wiggle room in these that could be based on almost anything, like why stigmatize the person, why cause their life insurance benefits to change. And then, so these data are not the best. We also have like data from Harvard where they actually interview people who overdosed and were rescued. These data are completely different and at odds with data that we collect in ongoing surveys. And I think 50% of the people who've overdosed tell the Harvard researchers that they either wish they die, they thought no one would care if they died, they thought it was a little bit like Russian roulette, or they actually wanted to die at the time of the last drug use. So when you add all that passive suicidal ideation together with active suicidality, they came up with 50% of the people rescued had enough suicidal intent for for that to have been considered a suicide rather than an accident. But prospectively, we think the numbers out in the field are usually reported under 20%. We have very little polling. And this is a good time of the year to talk about polling because we almost have like day-to-day data changes and polling data. But in addiction and drug abuse, we wait for the annual University of Michigan survey, which tells us what the trends are in teen use. And that's annual. That's very different than what we're used to in the United States, where we have our pulse on things with a variety of different ways to approach it. So we have coroner data, we have Michigan data, and then we have household data. All of that is collected, then analyzed, and in the latter, SAMHSA would put that out usually over a year after collection. Now, things change so fast in the United States that you could argue that by the time the survey comes out, it's obsolete. And I know from this work I've been doing for the Psychology Today, my articles, that when you talk to kids and look at trends, things are changing. So we had an article about ketamine misuse by teenagers. You have to really look very hard within the data sets that are published to see that ketamine use among teenagers, illegal ketamine use, is increasing. Same for nitrous oxide. So we have some things that are happening that are just not visible in the current surveys or hidden by other big changes like I just described. If you're describing a massive change in overdoses, you may miss the fact that cocaine and methamphetamine overdoses are actually increasing. So I'm answering your question by saying we have kind of old school data collection from high schools, from households, and from coroners that you almost have to put together to feel good about. The Michigan data we feel very good about because it's year after year after year. The longitudinal, the trending tends to be very useful, but we don't really know whether we're missing something big, and we think we are. We kind of find out after it's happened. We find out about the switch to fentanyl after it's happened. Now, another data source, by the way, is the DEA. So the DEA tries to confiscate illegal drugs, and the better they are at it, the more the price of illegal drugs go up. And so we have their seizure data and then the street price data. They're very interesting, and in my next article, I'm going to use the DEA data to describe what's happening with magic mushrooms. But suffice it to say that it would be very hard for the DEA data to be used, for example, during the fentanyl crisis or the methamphetamine crisis, or to help us understand that drugs now that are smoked are as lethal as drugs that are injected. That wouldn't be a role. So my answer would be we have to put all these surveys and data points together, and we could use Balmer to help us sift through them, but we could really use polling data and polling expertise that haven't been sufficiently applied to this problem to have more bites at the apple.
All right, so I'm taking away from the point you're making here, Mark, is number one, we're still dealing with antiquated means of collecting data that is relevant to understanding the problem, no less the appropriate responses, number one. Two, there has not yet been an aggregation effort to pull all these streams together, and hence there is an opportunity. And three, again, no centralized source of the data, so one has to think both inside the box and outside the box in terms of where data might reside and how to collect it, no less analyze it.
Yeah, I mean, if we do that, will make me obsolete. But it's one of the things that
No, I would say, Mark, someone still has to interpret the data. Okay. So I'm gonna AI has its limits. But what was interesting in terms of what you said, the DEA in their enforcement efforts, I would think that as they are acutely aware of the market price for certain things, as they're aware of what's coming into the country, what they're seizing, what they're generally seeing in their investigations. And you already alluded to, we'll call it I keep saying whack-a-mole, but the notion that cocaine use is on the rise. You have magic mushrooms and other types of things. At the very least, and the polling that could be done, okay, amongst the broad public, no less the enforcement community, that at least those data points could be, I'll use the term, better aggregated and better curated in terms of understanding what we're dealing with, not just in terms of the prior wars, but what's coming on the horizon.
So, yes, I appreciate you summarizing so well, and I agree. It just did remind me of one other thing that's important, and that is the researchers are people looking at the data sets and looking at the people who use drugs from the outside, and they're non-users. So when we describe them as people who use drugs, we miss the point that, in a way, this is a Matthew Perry point, which is to describe him as a people who use drugs really misses the pain and suffering and anguish. He's a people who has to use drugs. And that would be how he would be victimized by unscrupulous people selling him drugs at such a high price. When regular people look at that, they'd say, like, how could that be? How could he pay you that much for it? And I'd look back at Nora's earlier work, where she wrote a paper about addiction process and how it was a loss of free will. This isn't mean to excuse crime, and that but it was really meant to say that at some point in time, what they're thinking is not what you're thinking as a non-user. So when we thought about xylazine, which is added to drugs to potentiate them, and made the so-called zombie addicts, principally of Philadelphia, but now across the United States, where they had amputations and other things and just looked like they were just totally zombies. We could never understand it from the outside. From the user's point of view, they're reducing cost, they're potentiating the effects of the drugs, and they don't know or experience what they look like. A friend of mine who was the head of the Yale's substance use emergency department told me that when there were a bunch of overdoses, over 100 at the New Haven Green, and they had so many that the first responders called for help, and there were shortages of naloxone that were quickly remedied by Good Samaritans. He was curious about this and asked how this happened. How would you have this epidemic of overdoses in one spot? It was a word-of-mouth effect. So someone brought extra potent drug to the New Haven Green, someone or some people took that drug and were amazed by the intensity of the effect, and maybe then those people texted, called, told other people, and rather than avoid that drug batch, they sought that drug batch out. If you're not using opioids, you would never think like that.
So the point you're trying to make here in terms of understanding the crisis and not just what we have been facing, but what we are facing and are likely to face, is that there are a variety of perspectives, sources of data I'll go back to, that are essential, not the least of which is the data, the narratives that come from the user population in terms of what has happened and why it's happening.
Yes, psychiatrists have looked at this in one way by saying these are deaths of despair, because there's so many people who are depressed and there's so many people who are hopeless who are using. But that's kind of different than the change in perceptions, the change in reinforcement, the change in priorities that occur during the process of addiction, and change the person. And part of the reason that we want the earliest intervention and the most effective treatments up front is to prevent that process from happening. But we have a large number of people that we just don't reach, and we need to reach to make a difference, and we need to provide them with opportunity to get better and re-enter our society.
Okay, so as you were speaking, Mark, I couldn't help but think about the famous quote in Hemingway's The Sun Also Rises, when the question of one of the characters that was posed to one of the characters, I forget which one, but how did you go bankrupt? And the answer was something to the effect, two ways: gradually, then suddenly.
Well, that's perfect, because we don't understand really the process by which a cucumber becomes a pickle. A person who's using drugs occasionally becomes a person who can't conceive of their life without using drugs. So this process is insidious, like you describe, and if there was a switch process, we might be able to unswitch it. And I do think that's part of the focus of some of the new treatment research around, believe it or not, psychedelics, because they do have the capacity to reboot and reset the brain, where the current treatments that we have for substance use disorder are, for the most part, harm reduction treatments that don't pretend to say they'll return the person and return the person's brain and body to the person that they were before they were addicted.
So let me ask, I don't want to touch the third rail of politics, Mark, but I do want to perhaps tease out from you the fact that this has been a problem. This is our longest waging war. And, there really has not been a re-examination or rethinking. We've imprisoned millions of people around this war. We've lost millions of people. We continue to lose people. There is no data that can potentially even approach measuring the degree of suffering and loss that families have felt by this. And in my conversations with you and with Dr. Lesser and others, refer to this as the plague of 1 degree of separation. Everyone either has been impacted or knows a family relative or a friend or associate, colleague, etc., who has been impacted by this. And yet, Mark, and again, I don't want to make this a partisan conversation, but we have the elections coming up in November, and the highest office in our land is at stake, but so are various leadership positions on the state level, the city level, etc. And yet, these issues, and the, how should I say, the severity of the loss that is the consequence of addiction is not highlighted as a political priority. And maybe it's spoken about in terms of other issues such as, border security or what comes in from Mexico or China, and quasi-geopolitical issue. But I just haven't heard this, notwithstanding the fact that this has touched so many directly and indirectly. This it just hasn't been captured as a priority for anyone who is running for office. And I continue to be, perhaps naively so, puzzled by what this is and why this is.
I had the chance to work with some of the old-time pioneers, and if somebody wants to check out a few of them, I profiled Bob Dupont, who was the nation's first drug czar, right? And I interviewed him about this, and then I interviewed David Smith, who founded the Haight-Ashbury Free Clinic and who was probably the first addiction medicine doctor practicing in the community as a community doctor, and interviewed him about it. And of course, Herb Kleber, my mentor, worked at Lexington when that's where opioid use disorder patients were sent. I think it's just complicated. So in a way, it's not like COVID, where we're going to invent a vaccine and we're going to have treatments. And it didn't even work out that a vaccine was as good as we would have liked, or the treatments were as good, but it could help focus everybody. So the leadership at NIDA has focused on things that you could do with existing treatments. And you have to take your hat off to them. Like, you could increase naloxone supply. Now, it is true that was proposed in a paper and pencil exercise using AI by the Stanford group, led by Allison Pitt at the time. And they said you would get about a 5% reduction in overdose rates. That would be the single biggest impact, would be naloxone availability and people taking methadone. So you see the government's moving toward methadone and increasing availability of MATs like methadone and buprenorphine, because those are the two biggest things they could do. Those don't solve the problem, but you could have the biggest impact doing that. Now, I don't know how that works on a campaign where it's a line. It's complicated. It's not a partisan issue, I don't think, because Bob Dupont worked in the Nixon administration, and he's a Democrat, and then worked in a variety of other administrations. He was the head of first founding director of NIDA too, and would certainly not look at this in a partisan sense. I do think there are things out there that people that they're concerned about, their family being devastated by drugs, the fact that we're in a continuation of a drug epidemic that seems to have started in the Nixon administration, and that it just keeps getting worse and worse. So I might revert back and say that the drug historian David Musto, who was a Yale professor and colleague before his untimely death, called it the American disease, and that there's something about our entrepreneurial spirit and risk-taking and stresses and treatment-seeking and treatment system and prevention efforts that combine to give us this problem year in and year out. So it's hard to blame the politicians who are having a hard enough time explaining something like that they explain on the stump. I don't think either of them have had the kinds of experiences that so many Americans have had with overdoses and addiction in their family to talk from their heart. And I don't know that there would be any difference between them in support for the current policies and for parity and treatment for all. I don't know.
So I can mention to you that I remember during the Democratic primary and the Republican primaries, the most recent of which were, the active ones were back in 2016, and I think everyone on the panel, the respective panels, had been touched by this issue, but it was not even raised, Mark, and that's the issue. It just doesn't even seem to be raised, and we're focused on a lot of things, and a lot of things are justifiably, in the range of policymakers. But as your work, which goes back to the 70s, okay, attests, we seem to know a lot more than when we began, and we seem to have not only things that, it was interesting, you referenced naloxone, okay, back in the 70s, okay, most people think it was invented in 2015 or 2016, right? There are things that people are unaware of. There are potential options. There's no silver bullet. There are issues around stigma. There are issues about, how should I say, the unavoidable risk-taking of young people. And the reason I go to the Hemingway quote, as you were talking, my mind immediately went to it, is because this is what happens. People who involve themselves with in risky ventures, sometimes, it gradually, and some people get to walk away and they've dodged the bullet, but then suddenly some people just fall to it. And I know you're familiar with all this, but I just share with the audience some of the things I've learned through speaking with Mark. But I love the way the people, the authorities in the UK, designate overdose deaths, as death by misadventure. An interesting use of words.
Yeah, it is. It's just very, very sad. So yes, you always like to hear your issue discussed by the candidates, but really what we need is parity.
Right.
Like, if you have a chronic, lifelong relapsing illness, and they have likened it to diabetes, it should be treated like diabetes. Now, we have real problems coming up on the horizon here, like right now, if you looked at opioid use disorder, we have naloxone and nalmefene that can reverse overdoses. We have naltrexone, Vivitrol, buprenorphine, and methadone that can treat opioid use disorder, cause harm reduction, and prevent relapse as long as those medications are taken. When they stop, the risks go back really almost to the way they were before treatment began. So discontinuation is a new risk we're starting to see. Second, we have, as I said, cocaine, methamphetamine, combination with opioids, but cocaine, methamphetamine, you might ask, well, what are the treatments for cocaine overdose? Nothing. What are the treatments for methamphetamine overdose? Nothing. What are the treatments for cocaine use disorder? Nothing. What about the treatments for cocaine use disorder relapse prevention? Nothing. What are the treatments for methamphetamine overdose? Nothing. Methamphetamine use disorder? Nothing. Prevention of relapse? Nothing. So we have this terrible opioid crisis, and we have fantastic treatments. What are we going to do when we have no treatments?
And the answer, I would say, is there are people who have accomplished recovery from those substances. As you say, we just don't know why some people do, some don't. There's acquired wisdom along the way. There are the professionals that know of some things, some of which are not, they're not strictly, as you said, it's not the pandemic, let's find the vaccine, at least not yet. But there are some things that have worked for some people, and yet that is not shared, and I just don't see the concerted effort to give this to the families. And the partnership for, is it called the Drug-Free America, does some great work in terms of the things they put out, but it is so hard for families to know where to go.
So just think about it, if what you're saying, and I agree with, there are lots of people that went to residential treatment programs that have been focused on addiction, treatment, and recovery for decades. There are, however, the general public might not have the same access to those treatments as celebrities or sports figures, because they may have limited benefits. As we morph out of or into combination drugs, polydrugs, cocaine, methamphetamine, so forth, we're going to find that parity is going to be very important, even more important than it is today.
Okay, so when we talk about the great divides in terms of what I'll refer to income inequality, what you are also pointing out is that there's a great divide in terms of access to the resources that people need to deal with this pervasive problem. And there needs to be some degree of parity for everyone, because this is the one degree plague.
Yeah, I mean, so to me, that would have been my questions, would be related to can we do better on overdose reversal? Could the government help with that? Right. Can we do better on overdose reversal to treatment, to help people use that as a teachable moment and prevent the next one with treatment? Can we continue treatment so that we don't have a continuously relapsing evergreen overdose problem? And then can we have parity for treatment, especially for people who have dual disorders like depression and drugs, or anxiety or manic depression, or eating disorders and drugs? They're going to probably need more intensive residential treatment, which won't be available to many people. So to me, that I would have had 4 kinds of questions, and I'm not sure if that would separate the candidates or if the addiction is a voting block in any way. If it was, they probably would have paid more attention to the subject.
Okay, and I'll get away from the third rail of what drives campaign funds and financing. Okay. Mark, this has been great. I look forward to our next podcast and exploring what's emerging next on the horizon, your views on it. I also, because you've written beautifully about the dangers of marijuana, which the potency issues and the effect, particularly on young people's brain. I'll add the need for parity in our efforts to educate and prevent this issue, which will never be perfect, but a better job in helping to educate people. And since we've referenced Hemingway, Mark, let me also reference a bit of brilliant Greek literature and the land of the lotus eaters, okay, and the Odyssey, that even back then, in exploring the world, the travelers came upon the land of the lotus eaters. And if you may recall, the way to save the sailors, I believe, was they strapped them, bound them to the mast of the ship as they sailed away. But even back then, we knew about human risk-taking and some of the dangers of it. So, an ode to Homer. Okay. So, Mark, thank you. Continued great work, and we'll be posting your various articles alongside the podcast, so people can read and review. Thank you for the public service, Mark.
Thank you for your public service. I'm just doing my job. Thanks again.
Okay.
Thanks for listening to the RANE Insights podcast from RANE Network. Be sure to check out Dr. Mark Gold's full bio and host of written publications at psychologytoday.com. Want more RANE content? Find the RANE podcast series wherever you get your podcasts, or visit our website at ranenetwork.com. That's RANE network.com. Thank you for listening.